Okay, next we're going to talk about Kawasaki disease. Um, Kawasaki disease has an unknown etiology. It's most common in kids under 5. It's an acute systemic vasculitis. So the blood vessels are inflamed. The arterioles, venules, capillaries, and potentially medium-sized arteries, including the coronary arteries, all become inflamed. One of what happens with that inflammation is sometimes they develop aneurysms because those vessels are inflamed. There's a risk of coronary artery aneurysms. That's the most problematic part of this. There's a rare risk of a heart attack in the acute illness, but as those aneurysms heal and scar, that scarring can actually, it narrows the vessels, and so it can actually lead to heart attack later in life. Okay. What does this look like and how's it diagnosed? It's diagnosed based on clinical findings. There's not a specific test for it. A child needs to have had fever for more than 5 days plus 4 out of these 5 criteria. In the extremities, they may have redness of the palms and soles, and then later that peels. Bilateral conjunctivitis, but without drainage. So their eyes are very inflamed, but they don't have drainage. Changes in the oral mucous membranes. Their lips may be red, their throat may be red, and they may have strawberry tongue, where the tongue is swollen and inflamed, so that it looks like the pitted surface of a strawberry. A polymorphous rash. They may just have a rash that kind of may have different appearances, and cervical lymph node enlargement. Lymphadenopathies when the lymph nodes are swollen. So out of those 5 things, they need 4. Fever for more than 5 days plus 4 out of those 5 criteria. There are 3 phases. In the acute phase, they have an abrupt onset of high fever. It doesn't respond to antibiotics, and it doesn't respond to antipyretics. The symptoms appear over the next week or so. The symptoms may come and go, but the fever stays. They're also pretty irritable, which most kids with fever and the feel bads are irritable, right? When the fever ends, they go into the subacute phase. The remaining symptoms start to resolve, but those dilated arteries the arteries that were inflamed and dilated, they remain, and they may continue to enlarge. So during this phase, those aneurysms may actually get bigger. They're still cranky, okay? In the convalescent phase, when those arteries go back to their normal size, those aneurysms resolve, they're in the convalescent phase until their lab values resolve. This is 6 to 8 weeks. So in the acute phase, the heart muscle itself can be inflamed, and that can lead to dysrhythmias, valvulitis, and they can develop heart failure, okay? Those coronary arteries, remember the coronary arteries are the ones that feed the heart. They can develop aneurysms, and they get bigger, and then they gradually get smaller. And when that happens, they can have scarring. So during the acute and subacute phase, they can actually have a clot and have a heart attack, but they're more likely to have that as a late complication years later because of the scarring. The best prognosis is for kids who have no coronary artery changes. The worst is for the ones who develop giant aneurysms. Medical management, this is an inflammatory disorder and they don't know the cause. They give high dose IVIG, that's immune globulins. Salicylates is another time. We rarely give aspirin to kids, but they get it for this. It needs to be treated within the first 7 to 10 days for the best results. They keep taking low dose aspirin until their platelet count is normal if they don't have any coronary involvement. So if the heart and the vessels that feed the heart are not involved, they keep taking that aspirin until their platelet count's normal. If they have aneurysms, they continue that indefinitely. So they may take aspirin lifelong. If they have larger aneurysms, they may actually need additional anticoagulants because the risk is going to be, one of the risks is going to be of clots. Nursing care, They get INO, daily weights, and we assess for signs of heart failure constantly, because if the valves are affected, they can have heart failure. We want to relieve the symptoms, cool cloths, soft clothing, soft foods. The rash, we want to keep it lotioned and stuff. Respite for the family. These kids are fussy and miserable for weeks. So we want to help that family find some options for taking care of that child. We want to teach the family what to expect. They can expect desquamation, all those rash areas are going to peel, cranky, irritability, arthritis, that's temporary. They should not get live immunizations for 11 months after IVIG. And as long as they're on aspirin therapy, we need to be really cautious about giving varicella vaccine because it's a live vaccine, and there's a risk of we don't give aspirin to kids. There's a risk of another complication that we're going to talk about in the neuro lecture. I don't know why that just left my head. But we don't want to give aspirin to kids who may potentially have chickenpox, and varicella is a live vaccine. We also want to teach them what a heart attack looks like in kids, because it looks different. They may not have that crushing chest pain. When they're older, they're more likely to have chest pain and pressure. Littler kids may have crying that they can't relieve, restlessness, nausea, vomiting, abdominal pain. Okay. We also want to teach these families CPR because of the potential for arrhythmias. They need long-term follow-up, because usually at discharge from the hospital, we're not able to determine what the extent of the coronary damage is. So they're going to need long-term follow-up. I remembered Rice syndrome. I knew it would come to me if I didn't sit and try to think of it. We don't give aspirin to kids with viral infections because of Rice syndrome. So we do give aspirin to these kids because this is not a viral infection. All right, in the next section, we're going to talk a little bit about dysrhythmias.